Hi, I'm Jessica Orchard from the University of Sydney and Heart Research Institute. Today I'll be presenting our AF Smart 2 study on behalf of our research team. This study was one of the main research projects in my PhD. Here are my disclosures. Atrial fibrillation, or AF, is the most common arrhythmia and the prevalence is expected to double by 2050, driven by an ageing population and an increase in chronic heart disease. Current estimates are that AF accounts for as much as 1/3 of all strokes. AF is asymptomatic in up to 80% of patients and can easily remain undetected. If found and treated appropriately, most often with oral anticoagulants for those at high risk, AF-related stroke risk can be reduced by 64%. International guidelines, including Australian guidelines, now recommend opportunistic screening for people aged 65 and over. Our recent systematic review and meta-analysis showed that screening at a single time point identifies previously unknown AF in 1.4% of people in this age group. The problem is that in practice, screening is far from universal and there are many gaps. According to an evaluation by The Economist in 2017, in most of the countries surveyed, only a low proportion of patients in the at-risk age group were screened in the previous fortnight in primary care, with Australia near the bottom at 11%. As with all screening programs, AF screening requires a pathway to treatment. In many studies prior to the introduction of novel anticoagulants, only about 60% of patients with diagnosed AF were treated. The general practice setting is well suited to screening, as people over 65 visit the GP often, and there is a clear pathway to treatment for those diagnosed. Our previous studies have found screening in general practice using eHealth tools is feasible, and these studies have contributed to refinement of the tools. In Australia, as in many countries, people living in rural areas have more limited access to health services, including specialist cardiac care, and have worse cardiovascular outcomes. Therefore, rural general practice is potentially an ideal setting for upskilling GPs and nurses through implementation of innovative cardiac programs. Our key aims for this study were to increase AF screening and treatment rates in patients aged 65 and over in rural general practices by implementing a program using custom-designed eHealth tools. This was a cross-sectional implementation study conducted between September 2018 and June 2019. We recruited and trained staff at 8 general practices in rural New South Wales. All patients attending the practice aged 65 and over without an existing diagnosis of AF were eligible. Opportunistic screening was conducted by GPs and practice nurses at any patient visit. The screening program was supported by a suite of customised eHealth tools. These tools were integrated across platforms and covered all aspects of the screening program. Practices were also paid $10 per patient screened, up to a maximum number, plus $1,000 to cover setup and IT. I'll now explain each of the tools in more detail. An electronic screening prompt integrated with medical record software appeared when an eligible patient's file was opened. This prompt was part of an app located in a third-party hosting platform. It was designed to be visible but not obtrusive. The patient was then offered screening by the GP or nurse and provided oral consent. Screening was performed with a Cardia smartphone IECG, where you open the app on the phone and then place one hand on each of 2 silver sensors on the device. The app then records a lead 1 ECG rhythm strip, which you can see on the screen, for 30 seconds. At the end of the recording, the app provides an automated interpretation which is either normal, possible AF, or unclassified. The algorithm has been validated and has a relatively high sensitivity and acceptable specificity. The screening result was then entered into the same app that provided the prompt. All follow-up of those with abnormal results and all treatment decisions were at the GP's discretion. For patients with possible AF, the doctor would generally refer them for a 12-lead ECG to confirm the diagnosis. Once a patient was diagnosed with AF, the doctor could use the Electronic Decision Support app. The app is based on current guidelines and has been validated. This app extracted data from patient records to calculate the patient's CHA2DS2-VAR and stroke risk scores, then provided the doctor with evidence-based medication guidance to support treatment decisions. De-identified data were extracted from practices using a clinical audit tool. Extracts were done each month from baseline through until the end of the study. An audit and feedback process was used to provide regular reports to practices to assist with quality improvement. We also conducted a cost-effectiveness analysis of the screening program from an Australian health funder perspective. This model compared the cost of an AF screening program in general practice to the costs of diagnosed AF in the unscreened population. Sensitivity analyses were also conducted for different proportions of patients screened. Just over 3,100 people were screened in total across the 8 practices, and 36 new cases of AF were detected. The vast majority of these new cases were older patients and had at least one additional non-age or gender stroke risk factors. Overall, GPs performed about 1/3 of screenings and nurses performed the remaining 2/3. The mean proportion of eligible patients screened was 34%. And as you can see, half of the practices screened 40 to 50% of eligible patients. We did find that although these practices were very motivated, they weren't able to get above 50%, and we think this may represent a ceiling of the proportion we're able to capture in an opportunistic program. We've explored these issues in detail in a separate qualitative paper. In relation to treatment according to guideline, for those in the OAC recommended category with a CHA2DS2-VAR of 2 or more, the baseline treatment rate was 74%, which is relatively high. This rose to 82% for new screen detected cases, although this was not a statistically significant increase. The electronic decision support app was accessed for a small proportion of patients. Our cost effectiveness modelling showed that for population-based AF screening in Australian general practice, the incremental cost effectiveness ratio per quality adjusted life year gained was just over $16,500, and the ISA per stroke prevented was about $84,000. These figures assume a screening participation rate of 34% and treatment rate of 82% based on results from this study. These figures are well within accepted thresholds of Australian government health expenditure. Importantly, increasing the proportion screened from 34% to 75% would prevent an additional 1,700 strokes over 10 years with a negligible effect on the ISA. There were several limitations with our study, and the main one being the proportion of non-normal results according to the device algorithm of 17%. This added to the workload substantially for practices. So in summary, in the rural general practice setting, our AF screening program supported by eHealth tools screened 3,100 people across 8 practices, which was 34% of those eligible. Half the practices screened 40 to 50% of eligible patients, which may represent a ceiling of patients captured by programs like this. 1.2% of those screened had new AF confirmed. Treatment rates were higher than previous studies at baseline and trending upwards during the study, with 82% of new cases treated according to guideline. eHealth tools may be a valuable addition to future screening programs. And finally, our cost effectiveness modelling found that the program would be cost effective if implemented nationally. I'd like to finish by acknowledging our wonderful team of investigators listed here and to thank all the practices involved. Thanks very much.